The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. This is your host, Paul Wirkus. We're very fortunate this month to have two doctors on the podcast with us. We're talking about hearing issues, and we're here with Dr. Albert Park, ENT in the Department of Pediatrics at the University of Utah, and Dr. Adrienne Johnson, Doctor of Audiology at the University of Utah as well. Welcome back.
Thank you.
Thank you.
Albert, would you like to mention your disclosures again?
Sure. So I'm a scientific advisor for a company called Accreditation, which is developing a gene therapy for a condition called otoferlin, which we'll talk about, I'm sure, later, as well as on the advisory committee for the National CME Foundation. I have some grants through NIH as well as through the university.
Terrific. So I think those sound less like conflicts than making you eminently qualified to talk to us about these topics we'll talk about the next 2 weeks. We want to talk about congenital deafness this week. Albert, would you mind defining what congenital deafness is?
Yeah, I guess I don't actually like that term so much because I think in most cases, when we're seeing a family, it's not so much deafness, it's hearing loss. And so it's really the issue of congenital sensory hearing loss. And a lot of the diagnostic sort of odyssey or workup is to determine, one, if their child actually has a hearing loss. And if there is a hearing loss, is it involving one ear, both ears, and the severity? Because that, I think, really helps us then determine what the treatment is for them, maybe even helps us determine what the potential cause and prognosis. So that's sort of, at least, I think, what we tend to sort of focus on when we see these children, when they come to us, come to our attention. A lot of times what happens is they fail the newborn hearing screening, and then we try to get involved and meet the family right from the start. And I think that's really important, that the families have an advocate who really wants to work with them, tries to explain this really complex field that many of us spent years on, but the families unfortunately don't have that luxury, that they're suddenly thrust into this condition. They're trying to determine, with all the visits that they're being asked to essentially make and meeting all the subspecialists, and then trying to understand all this information, which I think is very daunting. But it's very important in terms of how we're going to be able to hopefully provide access to sound and hopefully to language for these children. I tend to think of it in terms of congenital hearing loss, and congenital is really hearing loss at birth, which should really be sort of distinguished from acquired, which is, I think, just as important and also is an important issue too. But the congenital is really important just because of the 136 milestones, and that this is really seminal data that a number of researchers, Christy Oshinaga comes to mind, who demonstrated that not only is it important to diagnose a child's hearing loss, but you want to intervene promptly. What she found really sort of through her work in Colorado was that if you identify a child early and you intervene with hearing aids or other rehabilitative treatments, prevention services, etc., that really has a huge impact in their child's speech and language over time. Even as early as 3 months, I think, makes a big difference. Her studies really focused on 6 months, and that's where sort of the rationale for the 136 milestones that we sort of adopted nationally, which means that any child who's born should undergo hearing screening by 1 month of age, and that a child who unfortunately fails their newborn hearing screening, get diagnostic hearing testing to determine whether or not that child has a hearing loss or not by 3 months of age. And then those children who are identified with permanent hearing loss, typically sensory hearing loss, those children should undergo early intervention and rehabilitative services by 6 months. And so this has sort of been our mantra, and this has been a focus nationally. And certainly this is something that we've adopted here in Utah.
Are there any big misunderstandings that you think get communicated to parents?
Well, I think we mentioned this in episode 1, that sometimes they do get some misleading information being told, like, oh, we realize your child failed the hearing test, but that's probably due to fluid or that, as Adrienne mentioned, vernix or something in the ear that will resolve itself on its own. And so they sort of downplay the sort of importance of the failed hearing testing. I think that comes up. That I think we still really struggle. We've done very, very well in terms of screening children, and we have this great collaboration with our Department of Health and Human Services, and they've done really great work in also trying to make sure children who are not born in the hospital, those children who are born at home, also are getting prompt and early screening. But I think the challenge that we are still experiencing is getting those children to get that diagnostic hearing test by 3 months, and even more so getting treatment by 6 months. And maybe that's messaging, maybe that's just a lack of awareness amongst all of us and including families. Also, maybe just the challenges. Families are busy, and this is costly in terms of trips to get to see the audiologist and getting the additional testing. We have great pediatric audiologists in Utah, but we don't have enough. And so that also, I think, can also be a challenge too.
Remind us of the prevalence of newborn hearing loss.
So the numbers are approximately 1.7 to 3 per thousand. So it is the most common birth defect actually in the US. And so again, to recognize the importance just in terms of the impact to the child, but also the prevalence of this condition. And that number doubles by the time a child's 5 to 6 years of age too. So again, very common.
Talk about some of the risk factors for congenital hearing loss or newborn hearing loss.
Well, there's a number of factors. So if you're a child or infant, newborn who's been exposed to ototoxic medications, been in the neonatal intensive care unit, prematurity, on a ventilator, those are certainly considered risk factors. Torch infections, which we'll talk about, cytomegalovirus, rubella, syphilis, those sort of infections also are an issue. But it's interesting, before the 1990s, we didn't have universal newborn hearing screening. And so a lot of it was based on sort of risk factor identification for newborn hearing loss. And we did not do very well. And the average age of detection of a child with congenital hearing loss before we implemented universal newborn screening was about 2 years of age. Well, gosh, 2 years of age, that's really late. I mean, at that time, the child should really have had a foundational set of language skills in terms of vocabulary, syntax, phrasing that, by two, if they have a hearing loss by that time, they're really behind the eight ball. So that really, I think, plus the work, as I mentioned earlier, in terms of the ability to really have an impact in improving speech and language early intervention was the rationale for universal newborn hearing screening. You mentioned a statistic last time that probably bears repeating. What percentage of children who are born with hearing loss have parents who also have hearing loss? So it's probably about 10%. Even though we feel that over 50% or at least 50% of children with congenital hearing loss could be attributed to a genetic cause, very few parents have hearing loss. It's certainly to the extent their newborn child does. And so most children who are found to have congenital hearing loss are born to parents who have normal hearing. Which is an important thing because it's a process for the parents as well. Yeah, and I think Adrienne really made an important comment on our first episode in terms of how we try to tailor our recommendations, our evaluation and treatment based on sort of a shared decision-making process where the families are really, it's really important for us to understand what the parents' values are, what their expectations and what they wish to accomplish for their child. And so that might be that they may want to pursue ASL or they may want to follow a pathway that may not be consistent with spoken language, which is fine. Or they may want to try to do everything they can for their child to be able to communicate with them through a verbal communication. And so again, that's where I think shared decision making is very important. And not usually something we would expect somebody to know instantly. It's a process to, I think, come to grips with the issue and to understand the ramifications of the issue. Yeah, there's a lot of handholding, I'm sure, in the process. I mean, in my practice, I often meet the families right after they unfortunately failed newborn screening, maybe at the time they're getting diagnostic hearing testing. But I feel like my role and people in my field are to really work with families through that process, trying to make sure that they're getting the absolutely best care in terms of interventions, and also to at least make sure that they're aware of resources for trying to determine the etiology of their child's hearing loss, being a resource to be available when things come up, seeing them regularly. I think that's really important. So you really do develop these strong relationships with the families.
You want families to have access to all the information so that they can make an educated decision for what they want their family and their child's life to look at. So it's important for them to meet with different people. This is where early intervention really is key so that they can meet with them and decide what path that they want to take. And they may pivot and change their mind down the road, and that's okay too. So our job as audiologists is to be supportive of families and help them reach their goals so their child can meet their full potential.
Very helpful. Adrienne, you want to give us a brief history of newborn hearing screening?
Sure, I would love to. So, as Albert mentioned, prior to universal newborn hearing screen, the average age of identification as a child who's deaf or hard of hearing was about 2 to 3 years old. For obvious reasons, this is where it was very apparent that speech and language was delayed, and at that point, they would get audiology involved. But at that point, we had missed out on so many critical years for auditory neural development for speech and language, and those kids had a very hard time catching up. So, really, recognition of that. And as Albert also mentioned, hearing screening used to be done on a risk based analysis. So, kids who had risk factors were tested with the hearing, but we were missing a lot of babies who had congenital hearing loss because of that as well. So, really, what changed a lot was in the 70s, is when the auditory brainstem response and otoacoustic missions were discovered. That these processes in the auditory system were being more well understood. Then in the 80s and 90s, the technology became commercially available for us to be able to test ABRs and OAEs. And there were some landmark studies that were done in the late 80s and 90s that looked at the feasibility of doing newborn hearing screens, knowing that it was accurate, that it was pretty cost effective. And again, like Albert mentioned, knowing that if we could intervene early, we could make significant improvements for outcomes for these kids. So in 1993, the National Institute of Health, NIH, they published a consensus statement saying that kids should have universal newborn hearing screening. In 1995, the Joint Commission on Infant Hearing followed suit with that. And then most states in the late 90s to mid 2000s had some sort of universal newborn hearing screening in place. And now most states have legislation. Some states, just everybody is really on board with universal newborn hearing screening.
Has there been a change in the technology from those early screening programs till now?
When we were talking about kind of risk-based and some of the newborn hearing screenings that were done before OAEs and ABRs, some hospitals were doing behavioral observation, which was not accurate at all. So really the big changes came with the discovery of OAEs and ABRs and the technology to be able to test that. Technology has gotten better as far as like being able to test in noise, being able to more accurately detect responses. Things like that definitely have gotten better throughout time.
Do you know when Utah got on board with the universal hearing screening?
Yeah, our legislation was passed in July of
I see.
1998. But really prior to that, most major hospitals in the state were doing universal newborn hearing screening. But in 1998, the legislation was passed requiring that. Also, the legislation requires we have home births. And in the state, so any child who is born with a birth attendant, the birth attendant is required to provide a hearing screen by 10 days of age. And then the other really important thing about that legislation that was passed is it required the state to form a newborn hearing screening advisory committee. And that committee still meets quarterly. I'm a member of that. Albert's on the committee. Anyone who has a stakehold in kids who are deaf or hard of hearing, through the screening, through the diagnostic, through the educational process, we meet quarterly to talk about any important topic that could be done to help these kids.
Well, let's go through how this plays out. Now, you mentioned last week that there are going to be some children who may fail an initial screening because of vernix or because of retained fluid. So what happens then?
Yeah, so in Utah, in regards to newborn hearing screening, we are what you call a two-stage screening state. So there is an inpatient hearing screening that takes place typically within 1 to 3 days of life, depending on how long the child is in the hospital. Now, this is very different for our special populations, our special care nursery, or for NICU. So we'll focus on our well baby population. So they have a screening before they're discharged from the hospital at birth. The majority of babies are going to pass that first screen. Hopefully around 95% of babies will pass. The 5% or so that don't pass, they come back for their second stage screening, and that should happen around 7 to 10 days of life. So they are screened again at 7 to 10 days of life on an outpatient basis. And again, the majority of those babies will pass. So about 85 to 90% of babies will pass the second stage screen. And it's thought that the reason why they didn't pass the first time was probably because of the issues we've talked about with debris in the middle ear or in the ear canal.
Let me just track that math then. So you're saying about 95% should pass the first screen, and then 95% of the 5% should pass the second screen.
So yeah, 85 to 90% of the
Okay.
5% should pass the second
Gotcha. Okay.
screen.
Okay.
What is really important to remember is our screening tests do not tell us why a child does not pass. So you cannot pass a hearing screen because of the debris. You cannot pass maybe because the child was very noisy during the test. You cannot pass because there is a hearing loss. So like Albert said earlier, it's really important not to minimize a failed hearing screen and say, don't worry about it. It's probably just fluid, because our screening measures don't tell us why a child isn't passing. So a failed screen looks the same for a child who has debris in their ear canal as it does for a child with a congenital significant hearing loss. So we never want to minimize a failed screening. We want to make sure that we're encouraging families and helping families get into their second stage screening.
So now if a child has failed the second stage screening, what's the process at this point?
Yeah. So two important things happen. One that we're going to talk about on the next episode is in the state of Utah, we test for cytomegalovirus at that point, the point where we're failing a second stage screen. And then we move on to diagnostic testing with a pediatric audiologist. And at that appointment, that is where we're really going to do our diagnostic testing using our battery of tests to determine how well a child is hearing and if there is a permanent hearing loss.
And when you say battery of screening, what technology are you using at that point?
Yeah, so our golden rule within audiology is that we never use one test to make a diagnosis. So when babies are coming back to see us for their diagnostic appointment after a failed second screening, we're doing diagnostic auditory brainstem response testing. We're doing diagnostic otoacoustic emission testing. And we're also doing admittance testing and looking at function of the middle ear system. I describe it to families as putting a puzzle together. So each of these tests is giving me an important piece of the puzzle so I can get an idea of the big picture of the function of the auditory system. And we are able to accurately estimate hearing sensitivity when we are using this test battery approach.
So it's basically what you might call a belt and suspenders. You're using a backup technology that will measure things slightly differently to be able to ascertain if this is a failed screen or not.
Yeah, so every test that we do tells us about a different part of the auditory system that we're looking at. So tympanometry, which is a very important test, tells us about middle ear function. Otoacoustic emissions tells us about outer hair cell function, and the auditory brainstem response test tests kind of the whole auditory pathway and tells us how sound is getting up to the level of the brainstem.
Okay. So
for
Albert,
instance, one of the most common, sorry, I was going to interrupt.
No,
Paul.
that's
I was
fine.
going to say that one of the most common scenarios Adrienne and I will be challenged with is a child who actually fails newborn screening, but then has abnormal tympanometry, so middle ear fluid issues. And that is, again, I think, an important issue because it's very easy to say, oh, well, that child has fluid, and so we don't need to really be too concerned. And, maybe we can just allow that fluid to hopefully resolve over the 6 to 12-month period. But we've actually published on this, and we found in Utah that, a very large cohort of children who presented in that fashion, they failed a newborn screening, they're found to have middle ear fluid. About 10% of those children actually were found to have permanent hearing loss. So it's very important, even in that scenario, to do your due diligence, that you need to get timely diagnostic hearing testing in those children. That might even involve placement of ventilation ear tubes. but it also means that we try to get diagnostic auditory brainstem response testing done again following that 136 milestone. So that's one scenario. I really like Adrienne's point about the jigsaw puzzle. Like you're using different components to kind of answer different questions. It also is important because I think it validates the results too. We don't want to rely on one test because this is really important stuff. This is very important, and this has long-term ramifications for the family, for the child. And so we want to get it right. We want to be sure that if a child has a permanent hearing loss, that to the best of our abilities and technology, that we get that right. And so that's part of sort of our due diligence. That's why we do this testing, which can sometimes take a long time to do because, again, of its long-term implications.
And it would seem as well that if it's an issue of fluid behind the eardrum, that whatever the cause, your argument last week was first several months are still very vital for language communication development. And so to say, we'll see if that gets better would miss the point in some of those kids.
Is it worth talking about the special needs children too? Would that be
Sure. Yeah,
helpful for the audience? Because I
absolutely.
know that Adrienne, you've talked about the well baby, but I'd be curious to see what's done in the NICU. And I know you've done a lot of work in trying to improve that process too.
Yes. Do you want me to talk about our diagnostic testing in the NICU?
Yes.
Yeah.
Okay, perfect. So we talked earlier how we have different protocols for well baby, newborn hearing screenings, and special care or NICU hearing screenings. So our guidelines, the Joint Commission on Infant Hearing, are EDI, which is Early Hearing Detection and Intervention. We have very specific guidelines for how we do the screening. And OAE, or otoacoustic emission, is a very appropriate test to use for a screening measure in the well baby population because their risk of having a neural hearing loss is actually very low. When we're looking at our NICU population and our special populations, they have a higher rate of having a neural hearing loss, and an AABR is the screening method that needs to be used in babies who have spent time in the NICU because that actually tests for auditory neural function. So babies in the NICU, it really is hospital dependent how that screening and diagnostic process looks. We, in our hospital here, and I know at a lot of hospitals within Utah in the NICU, once a baby fails a hearing screen, if they haven't already had CMV testing, we get it done at that point. And then typically we move straight to a diagnostic testing, hopefully done while the child is still in the NICU, so the family doesn't have to come back after an extended hospital stay for hearing testing. So here at our hospital, we fail a hearing screen, we do CMV testing, and we move right to a diagnostic test so that we can provide that information to families before they leave the hospital. And it also could help with some other medical workups that the child could potentially be receiving. If, like, a geneticist would know that this child has a permanent sensory neural hearing loss, that can be valuable information for the medical team. It's also valuable information for all the caretakers of that baby. When you have a child who's deaf or hard of hearing, you interact with them different. And so it allows us to work with nurses, with doctors, with any caretakers, and make sure that that child who has a hearing loss, that people are aware of that and that they work with that child differently, knowing that.
It's amazing. It's such a process and allows much earlier intervention of any kind to be able to know what's going on with those at-risk children. Do you want to mention a little bit about what OAE and ABR are actually measuring?
So OAE, again, otoacoustic emission, this is testing outer hair cell function. So we know that when sound waves enter the cochlea, it causes the basilar membrane within the organ of Corti to move. And the outer hair cells, they detect this vibration and they respond by changing their length. So they expand and contract, and this causes something we call electromotility. So that electromotility actually enhances the movement of the basilar membrane and amplifies the sound, which makes it easier for the inner hair cells then to respond to, that connect to the nerve that goes up to the brain to be processed. So that outer hair cell electromotility, or that expansion and contraction of the outer hair cells, that actually generates a mechanical energy that is then propagated outward through the middle ear system into the ear canal, and we can measure that as acoustic energy. Anytime I talk about it, it's crazy that we can do this. And
Right.
so we're measuring that acoustic energy. And from there, we're able to tell if the outer hair cells are functioning normally. So OAEs essentially, right, are a byproduct of the cochlear amplification process. And when we measure these as means of a screening, again, it's just pass or a fail. But when a pediatric audiologist is doing a diagnostic OAE, we're actually able to look at data. We look at the amplitude of that OAE response. We're looking at signal to noise ratios, and we're looking within certain frequency bands. And we're able to gather a lot of information of outer hair cell function across frequency range. So then we can look at that and we can compare it to an ABR. So the ABR, again, is an auditory brainstem response test. This is an evoked potential. So we're putting electrodes, different points on the baby's head. We're putting different stimuli into the ear. So we're looking at different frequency ranges, different frequencies at different loudness levels. And when we put sound into the ear, again, that evokes a response that's time linked to a stimulus. Over time, we use signal averaging to average out noise of the baby or electrical noise, and that leaves us with a neural response. So we're able to pretty accurately estimate hearing sensitivity. I will say the ABR only works when a child has a functioning auditory neurological system. So there are certain types of hearing loss, such as auditory neuropathy, spectrum disorder, sometimes referred to as auditory neuropathy synaptopathy, where the ABR is not an accurate predictor of hearing sensitivity. And in that particular disorder, you have normal function of the ear up to the outer hair cells. And then beyond that, there's some sort of dysfunction, whether it's with the inner hair cells or the synapse of the inner hair cells to the eighth cranial nerve, or perhaps even an absent nerve or a hypoplastic cranial nerve. So in that specific case, the ABR cannot accurately predict hearing thresholds. And that's where we have to wait for time when a child's
Mm.
old enough to do the sound booth testing that we talked about earlier that really gives us their information.
A good reminder. Albert, which of these kids are going to need imaging? Do you do imaging routinely as part of the workup?
That's a great question. We try to be a little bit cognizant of resources and try to prioritize the ones who I think would benefit most from it. You're kind of alluding to the diagnostic workup, I guess, of a child with permanent hearing
Right,
loss.
right.
And so we'll talk a little bit more about the CMV issue, but that's one of the first things
Yes.
that we do. And the rationale for that is really because diagnostic testing really depends on trying to get a child before they're too old. When they're over 21 days of age or so, then you're having confounding effects of postnatal CMV infection. CMV is like any virus, you can get it at any time, but it's associated with the congenital aspect of things. And then we oftentimes look at really what the degree of hearing loss is. Now, if we have a child who unfortunately has an ANSD picture, for instance, what Adrienne was talking about, where the otoacoustic emissions classically are present, but then you're seeing an abnormal neural response. And I don't know if we want to go into too much detail in terms of some of the subtleties to that. But in that situation, we often will want to go ahead and get imaging because that has real significant ramifications in how we treat these children. Unfortunately, in many situations with that presentation where the otoacoustic emissions are present and there's an abnormal auditory brainstem response study, it's not uncommon that they'll have an absent cochlear nerve. Well, if the nerve is missing or is severely hypoplastic, then you're not going to get the signal to the brain. I tell the family, even the strongest amplifier, the strongest hearing aid is not going to really do it for them. And that also has implications for cochlear implantation. So that's a situation where we would probably want to image that child sooner rather than later. Another situation also is in the congenital CMV infected children, because about 10% of those children will have central nervous system abnormalities. We're imaging not only for the temporal bone aspects of things, but we're also imaging the brain. And so actually we have a great protocol that was started maybe 10 years ago with Gary Hedlund when I was telling him, I have this kid who has congenital CMV. Do you mind if we do a brain MR while we do the temporal bone? And then he came up with the great idea, well, why don't we just do brain MRs on all the kids that we get temporal bone imaging? And so that's sort of been the protocol at Primary Children's for at least 10 years or so. And that's a situation, again, that will get imaging. But imaging is a little tricky because especially if you're doing MRI imaging, which I think is sort of the standard in most cases, because you're wanting not to have these children exposed to ionizing radiation, but that's a test that takes a long time. And at least historically, a lot of these children required sedation, but we don't want to sedate a child unless it's absolutely necessary. Now, with collaboration with our pediatric neuroradiologists, we've developed protocols where we're doing more and more of those MRI temporal bone / brain images with natural sleep, where we swaddle the child, we feed them. As soon as they come in, we kind of get them a little bit sleep deprived, which unfortunately means the mom and parents are also a little bit sleep deprived, but we try to do that to avoid the issue of sedation. But there are situations where we still have to sedate. So a lot of times when I'm looking at diagnostic workup for these kids, I'm trying to determine what is the test that maybe would avoid sedation, that would provide answers. And so that's where we often do genetic testing too. And this is really a collaboration that's been started with John Carey back in 2006, when John and I talked about how do we do a better job in helping work up these children on a more timely basis. And since, again, about 50% or more of congenital hearing loss could be attributed to genetic, that's when we started that clinic where we started seeing patients together. And that clinic has actually grown into a center where we have pediatric audiology, speech and language pathology. We have a genetic counselor, Janice Columbus. And now we have Dr. Abdul Elias as a geneticist. Since unfortunately, John, I wish he had stayed forever, but he went ahead and retired. And so we had to find another geneticist. No one can replace John, but Dr. Elias has done a great job. So we have this sort of great collaboration. We often will talk about these sort of cases. We see these families together, and that way we sort of streamline, personalize what the workup is. But in a general sense, I try to mention just kind of the different tests that we provide for the families.
Very helpful. Anything else that we ought to be saying about congenital hearing loss diagnosis? Next week, we want to talk about intervention. Thanks so much, Adrienne Johnson and Albert Park. This is very informative. For those of you who have questions, please send your questions to questions@vcurb.com, and we'll deal with those in a couple of weeks. Thanks again for your time, and we'll talk to you next week. Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design, thanks to Paul Wirkus, who also composed the theme music. See you next time.